Good afternoon. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Welcome to today's National Latinx AIDS Awareness Day webinar. HIV and AIDS disproportionately affects individuals of color. While Latinos make up only 17% of the United States population, 27% of new HIV diagnoses are Latinos. Most of these new diagnoses are among gay and bisexual men, and the numbers are increasing the most among those in the 25 to 34 years of age group. 1 in 6 Latinos with HIV do not know that they even have it. During today's webinar, we will learn more about the impact of HIV on the Latino community, barriers to testing and treatment, and recent advances in HIV prevention. We are pleased to be joined by our guest panelist, Shane Judge, PrEP counselor for Robert Wood Johnson University Hospital Somerset's Bab Sipperstein Proud Center, and Dr. Raul Gonzalez, family medicine resident at Robert Wood Johnson University Hospital Somerset. Thank you all for joining us today. So why don't we start by each of you introducing yourselves and telling the audience a little bit about you. So why don't we do ladies first? Shane, if you would kick us off.
Thank you so much. Hi, my name is Shane. I am the PrEP counselor for the Bab Sipperstein Proud Center at Robert Wood Johnson. And as part of my role, I typically work with all PrEP patients, whether they're interested in PrEP, whether they were recently exposed to HIV, or if they're already on PrEP. And I help them with conducting a risk assessment, so seeing where they're at with their behaviors. And then I walk them through risk reduction counseling, so how we can practice safer sex, how we can practice safer drug use. And from there, I also help with cost assistance. So I help them connect to programs that help with covering the cost of PrEP, as well as conducting educational outreach like this.
Great, thank you and welcome again. Dr. Gonzalez.
Hi, so I'm Dr. Raul Gonzalez. I am based out of Somerset Family Practice. I'm a resident physician in my 3rd year there. I work both in the outpatient, inpatient, and OBGYN settings, and we treat a kind of, I'd say a lot of my population is kind of underserved Hispanic population as well, just due to the language alone, but we see anybody and everybody in our office.
Great, well, thank you and welcome again. So why don't we start off, if you can give us an overview of what is HIV and AIDS and how is it transmitted? So who would like to take that, Dr. Gonzalez?
Sure, yeah. So HIV, it's a virus. It's a virus that attacks our body's immune system. What happens is if the virus attacks our immune system, or if it persists for long enough, it could lead to something called acquired immunodeficiency syndrome, better known as AIDS, where essentially our body really doesn't have a defense against anything and everything. Currently, with regards to HIV, there's not really an effective cure. Once someone has it, they essentially have it for life. The thing is, though, with our medical advances, with proper medical care, HIV can be controlled and people can have kind of long, healthy lives, as long as with their partners and families as well. That's kind of a little bit of the gist of what HIV is.
Great. Shane, did you wish to, let me know if you wish to, feel free, jump in and add anything too.
As far as transmission, blood, semen, vaginal fluids, rectal fluids, and breast milk are typically how it is transmitted.
Great, thank you so much. So while HIV and AIDS cases have dropped significantly since the height of the AIDS pandemic in the 1980s, it is still a major health concern. So why don't we start off, let's talk about who is at risk. Dr. Gonzalez?
Sure. So as Shane was mentioning, it all depends on kind of transmission. HIV is passed on from person to person. It's usually passed on via different methods, the most common one being blood. And then it could also be through fluids from sexual interactions. So people can get it from anal, vaginal sex, sharing needles, syringes, the people that are most at risk for HIV are people who are having anal sex with somebody with HIV without condoms. That's usually the riskiest kind of transmission that there is. But obviously there's anything that's associated with blood, like I mentioned, sharing needles. There is penile to vaginal contact that could be also cause of transmission. Some that are kind of less common, but it's usually not in the salivary gland. So if like someone biting and things like that, or spitting, usually it's not a form of transmission. There has been kind of like the small cases here or there, but it's usually when there's blood associated with it, cuts from people's mouths, or when they're able to penetrate the skin on bites, that kind of thing. Sometimes from medical care, from blood products. Obviously, we screen everything. We do as little risk as possible. Tattooing and piercing, but usually if they're using like incorrect needles, once again, if you break that skin barrier and you're using same needles on everyone, but less common. Mouth kissing or anything like that is usually not a form of transmission, but once again, if there's an open cut or anything, that could be something different.
Thank you for that great explanation. So then what are the testing options that are available, and who should get tested and how often?
I can do this one. So as far as testing, there's nucleic acid tests, which are a little bit more rare. These are blood tests that look for the actual virus in the blood draw. There's also antigen and antibody testing, and this is the most common that you'll see. These are either rapid tests or a blood draw, and rapid tests can come back within 30 minutes or less. And as far as the blood draws, they typically take a few days for results. And antibody and antigen testing are testing for antigens, and those are foreign substances introduced in the blood that can turn on our immune response, or antibodies that are helping our immune response fight the virus. And testing, you should typically get tested every 3 to 6 months if you're high risk. So if you're having high risk sex, anal sex, as mentioned before, especially receptive anal sex, or IV drug use, that would be every 3 to 6 months. Otherwise, about once a year is good for routine healthcare.
Okay, great, thank you. Dr. Gonzalez, did you want to add anything?
Yeah, just to add on to that with testing, with like medical wise, we've made so many advances. The thing is though, right now, there's nothing that is able to test HIV immediately after exposure. So usually there's a little bit of a window period with regardless of whatever test we have, where someone could kind of test negative, but still have positive after exposure. So really, if anybody's getting tested, talk to your doctor as to when you got exposed, what the exposure was. Because usually at least in the office, we don't, if somebody's like immediately tested, we might test it right then, but we also wait a couple months afterwards and retest as well, just to make sure, because there's a window period where it usually won't be detected by any of these tests. And people would generally be asymptomatic for it as well.
Okay, well, and thank you for bringing up symptoms, because where you're talking about being asymptomatic, let's talk about what are the symptoms of HIV and how maybe somebody, aside from knowing that they're in that high risk category, know that they might have it. So who would like to explain what are the symptoms of HIV?
I can do that.
Okay.
As far as the symptoms, they're typically flu-like symptoms. So fever, chills, rash, night sweats, fatigue, sore throat, swollen lymph nodes are often a sign of it, and mouth ulcers. But as Dr. Gonzalez mentioned before, it's often asymptomatic, which means you have no symptoms.
Great. Dr.
And
Gonzalez?
not to scare anyone, like Shane just said, they are flu-like symptoms. Just because you have flu-like symptoms does not mean you have HIV. We always look, at least in the office settings, obviously these high-risk behaviors, these high-risk exposures that we talked about, and kind of coordinate our testing accordingly. But it is something that is usually asymptomatic until we find other causes when it's more advanced a lot of the times as well.
So why do you feel then the HIV transmission among Latinos is so high? Like what are the barriers that prevent individuals from getting, tested and treated? Dr. Gonzalez, from a patient perspective that you're seeing.
A lot of the time it's access. I think that's one of the main barriers. A lot of people don't have insurance. A lot of people don't know where they can get tested. There's lots of free clinics around that do testing, but unfortunately people are not aware of or not sure where to reach out. The other thing is just lack of kind of information or education about those sexual practices or those high-risk behaviors within that population to get tested for HIV regularly. I think that puts a lot of kind of strain on the population itself to kind of not be tested or to get the lack of testing in itself.
Okay, great, thank
To
you.
add to what Dr.
Go ahead.
Gonzalez said, the lack of comprehensive sex ed in Spanish, I think, as far as the language barrier goes, is a huge barrier. Because, like he said, those safer sex practices are not translating over because we don't have the language there, as well as, you know, fear of disclosing immigration status and accessing healthcare.
You know, great points, both of you. And in fact, we're in the process of doing our new community health needs assessment. The lack of culturally and linguistically appropriate materials all around in the education system, that did come up. So it's very interesting to, you know, also hear it, you know, having just done this assessment. So thank you both. So now I know both of you have been, Dr. Gonzalez, have been talking about the great advances, right, that have been made in HIV prevention, particularly with the introduction of pre-exposure and post-exposure prophylaxis, or PrEP and PEP, as we kind of tend to term them in the medical field. So can you explain more about PrEP and PEP? Who is eligible for each? How do they work? How effective are they? Just to start there. So Dr. Gonzalez, would you like to kick us off?
Sure, yeah. So PrEP is pre-exposure prophylaxis. That's mainly for anybody who is a known HIV negative individual who may be in kind of these high risk exposure areas. If it's somebody that's an IV drug user, that's going to continue being an IV drug user, PrEP could be a candidate for them. If it's somebody who's in kind of like the sexual industry, if there's somebody who has sexual risky practices, obviously man to man is a high risk, and they're no negatives, they are eligible for PrEP. The PEP, the post-exposure prophylaxis, that's usually for anyone who has been exposed to a known HIV source. So it could be through sexual transmission, could be IV drug use if they weren't sure if they were sharing needles or something like that with somebody that was, or a common one that we see as well is in the hospital settings, hospital workers who get exposed, needle pricks, or someone who is at high risk or is known to have HIV as well. That's kind of like the basic. I don't know if Cheyenne can have more of an input on that as well.
No, you covered all of that wonderfully. The only thing I would add is just that PrEP is a very effective method. These tools are incredible advances, obviously, in medicine. And PrEP reaches its peak effectiveness typically after 7 to 21 days of taking it. It's an everyday medication, and it is 99% effective at preventing HIV when taken correctly.
Great, and thank you for covering. I was just about to ask you how effective they were, and you took the words right out of my mouth. So is there any financial assistance available for those who cannot afford these medications? Because, you know, we hear in the community all the time, you know, people can't afford some of their prescription medications.
Yeah, so I actually, typically I work with this a lot. We have a lot of times patients who can't afford PrEP just for other circumstances. They're very costly drugs sometimes. And so Gilead, the manufacturer, has a great program called Gilead Advancing Access. And this can cover the copays, the visits, and the cost of the medication. And all you have to do is go online or by phone and apply for this. And sometimes there's income requirements. But then there's also programs like Ready, Set, PrEP, and this is a program that covers those with a lack of prescription drug coverage, and it often covers the drug up to 100%. So these are great resources that are out there, and they cover PEP as well, the manufacturer programs. So these are great resources that we have for our patients.
That's great. That's fantastic. So again, we've discussed, you know, there's been so many tremendous strides made in the treatment of HIV and AIDS over the past several decades, allowing individuals to live longer healthy lives. So tell us about the treatment options that are available. So Dr. Gonzalez, why don't you kick that one off for us?
So in terms of treatment, there's a varying vast amount of medications to treat HIV once someone is known to have it in itself. They're usually antivirals. The goal is to kind of prevent the viral replication, to prevent the viral spread, to keep it controlled. Like I said earlier, HIV is something that someone lives with throughout their lifetime. So the name of the game is always trying to get your viral levels controlled, so that way people who have low viral loads limit their exposure to either partners, limit the disease progression as well. There is a vast amount of different medications out there, and I think that's more of a goal once somebody has it, to try to kind of get with an infectious disease doctor, because they're the ones that normally manage the different types, because sometimes the key thing is trying to avoid resistance to the drugs. And that has to do a lot with compliance. Some patients, for whatever compliance reasons, don't take their medication on a regular basis, and they could build kind of some resistance. So at that point, we have to do additional testing to see as to what medications can work for them and how we can manage it. It's a very, very complex field. It's a very, very complex medicine, but it does work great. There's lots of great results with it. I don't know if Cheyenne has anything to add to that, or.
No, I think you did a great job, especially just the way that we've used these medications to suppress the viral load in people, and understanding that now we have U equals U, which is a phrase we commonly use for undetectable equals untransmissible, which means if we can get your viral load low enough that it's undetectable in your system, you can't transmit the virus to a partner, which is groundbreaking.
Great. Thank you. So now again, among Latinos who are diagnosed with HIV, their adherence to treatment is lower than other ethnic and racial groups, and they tend to have lower viral suppression rates than others. So can you explain that? Dr. Gonzalez, do you want to?
I think in the Latino kind of Hispanic community, obviously there's a lot of negative connotations with anybody who with HIV getting tested for HIV. That might play a role into it. I think lack of awareness of, like Shane was mentioning, of safe sex practices, of the proper education of when somebody's diagnosed with HIV, or also, like I said earlier, follow up with them. It's a medication. It's a disease where you have to be very compliant. It's hard in certain communities because sometimes it's hard to see your doctor every week. You have work, you have kids, you have everything else going on. And not only that, it's hard to kind of pay for all that. It's not cheap kind of treatments or medications, but I think all of those around, along with some cultural biases, may play a factor into it.
Okay, great. So then what are your organizations doing to help address health disparities in the Latino community, particularly with regards to HIV and AIDS? Do you want to take that? Actually,
I can start it off.
sure.
So the Babs-Zipperstein Proud Center, we have an incredible staff. We are a small staff, but a great staff. And we have 2 Spanish-speaking staff members, which really helps us communicate with patients who have the language barrier. We also have a PrEP counselor. So I am able to work with the patients to help with prevention, because that's a huge part of it. If we can get in front of it, prevention is our first line of defense before treatment. We also offer culturally sensitive healthcare and LGBTQ+ sensitive healthcare. And this helps us with that population of Latinx people who are gay, bisexual, lesbians. Those populations we're able to reach because we offer not only, we have Spanish speaking staff, but we also understand the culturally sensitive material there. We also offer support groups and educational groups. And as Dr. Gonzalez mentioned before, we have an infectious disease specialist on staff, which is incredible because he is very, very up to date with HIV treatment and prevention.
Okay, great. Well, thank you. So what I would like to do is just give our audience an opportunity to ask you both some questions. If you have a question for either Dr. Gonzalez or Shane, please post that in the Q&A section. of our webinar. We'll be happy to field those questions and ask on your behalf. So, so again, what do you, when working with the community, while I'm waiting for some questions, I want to give them an opportunity. When working in the community, what do you feel is the biggest need in order to prevent HIV and AIDS? Would it be the cultural and linguistically appropriate materials, or like what are you seeing, or is it really access? And I know you both probably have two different perspectives, so.
Yeah.
I think proper education is very lacking on safe sex practices, whether it's at the doctor's office, whether it's in schooling, whether it's culturally. I personally don't think we do too good of a job for it. Obviously, the best way to treat and get rid of HIV is not getting in the first place. So like Shane was saying, not reaching those audiences or teaching those practices to prevent or to lower your risk of exposure transmission, I think would be the key thing to prevent needing treatment, to prevent needing access, that kind of stuff. I think would be do wonders for the population.
I completely agree. I think that with a background in comprehensive sex ed, even I worked in Newark for a while, and they have a large Spanish-speaking population, and our materials were not designed for them. And we worked to update those materials, but it's too late at that point. This should have been done a long time ago, and we need to be reaching these populations now in order to prevent HIV and the spread of it, like we said.
Wow, thank you. Well, that's good to know, because like I said, that's coming out in the needs assessment, and that's something we can definitely work on here at RWJ Somerset. So sound very good. Well, I'm just looking, it doesn't seem like any of our audience members have any questions for either one of you. So if there are no questions, then this is actually going to conclude today's webinar. And thank you both for joining us as panelists today, and for our audience for attending. It was a very enlightening discussion. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. And for more information about healthcare services at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjbh.org/Somerset. Thank you all for attending. Have a wonderful day and be well. Take care.